Assalamualaikum and a very good afternoon. It is a privilege for me to deliver a talk in the Respina Virtual Conference 2021 with the topic on Transport in Respiratory Failure Patient, Managing Risk in Transporting Patient. And I have nothing to declare. Life support, including for those respiratory failure patients, is sustained by four very important life functions: ventilation, oxygenation, circulation, and perfusion. Ventilation, the first and the most important in this case, is movement of air in and out of the lungs. Ventilation depends on a negative pressure generation within the thoracic cavity, which draws air into the upper airway. This process requires coordinated interactions between the musculoskeletal, respiratory, and central nervous systems and provides fresh air to the lungs with each breath. Mechanical ventilation uses positive pressure to drive air into the airways using the mechanics of a ventilator. And we are going to discuss more on this particular point. And for sure, ventilation must be maintained even during the transport in the ambulance. Those patients with respiratory failure, maybe due to hypoxia, hypercarbia, acidosis, or fatigue, are indicative for ventilation. We know that there are criteria for institution of ventilatory support, clinically based on pulmonary function studies or with arterial blood gases measures. But healthcare providers, especially those who are working in the ambulance, most likely will not have this information. So the decision to intubate is based on the patient's degree of respiratory distress and the provider's clinical expertise. They can rely on these five items respiratory failure signs, which can be easily examined even during the transport in the ambulance. So, a protocol must be instituted for transport in respiratory failure patient, as it has an important role in managing risk, not only for improving oxygen saturation by delivering supplemental oxygen with breathing devices, but also for improving partial pressure of oxygen with mechanical ventilator. Some patients may require mechanical ventilation because of a condition where the mechanics or ability to breathe is impaired. This may include drug overdose, brain trauma, neuromuscular disease, musculoskeletal defects, or respiratory distress syndrome. A ventilator is defined as a mechanical device for artificial ventilation of the lungs. The mechanism may be hand operated or machine driven, and in the latter case, may be automatic and very sophisticated with respect to being able to maintain or improve ventilation and tissue oxygenation, to decrease the work of breathing, to improve patients' comfort, and to minimize the risk of lung injury. Let's talk more on transport ventilator. When pre-hospital providers initiate mechanical ventilation, several parameters must be set on the ventilator depending on the complexity of the ventilator in use. When pre-hospital providers take definitive control of the airway, they place another type of tube that provides a pathway to replace the upper airway. This may include performing endotracheal intubation or placing a combi tube or even laryngeal mask airway or LMA. Providers can then initiate continuous ventilation, taking into consideration the patient's immediate needs and overall condition. Mechanical ventilation is not therapeutic. Its function is to maintain a patient's ventilation and provide time for medical treatments like drugs, surgery, or other procedures. Let's help make it simple for pre-hospital providers. What should they do if the patient still can't breathe by himself? The simplest transport ventilators use the control mode. It's often used as initial mode of ventilation. As the ventilator provides the patient with a preset tidal volume at a preset rate, the patient may initiate a breath on his own, but the ventilator assists by delivering a specified tidal volume to the patient. Patient can initiate breaths that are delivered at the preset tidal volume. The total respiratory rate is determined by the number of spontaneous inspiration initiated by the patient plus the number of breaths set on the ventilator. But it has disadvantage, hyperventilation. The other mode is synchronized intermittent mandatory ventilation or SIMV, in which the ventilator provides the patient with a preset number of breaths per minute at a specified tidal volume and FiO2. The tidal volume of this breath can vary drastically from the tidal volume set on the ventilator because the tidal volume is determined by the patient's spontaneous effort. Allowing the patient to take spontaneous breath on his own without triggering the ventilator into a positive pressure cycle. It means no fighting. A patient requiring transport from one facility to another who is receiving mechanical ventilation and is able to maintain adequate oxygenation should be managed with this mode. And how if the patient cannot breathe? This control mode should be used with the patient who is completely apnea, including patients sustained on neuromuscular blocking agents, where ventilation is completely provided by the mechanical ventilator with a preset tidal volume, respiratory rate, and oxygen concentration. Ventilator initiates and totally controls both the volume delivered and the frequency of breath. This mode delivers a set amount of positive pressure ventilations, so a patient cannot trigger any additional breath when this mode is used. While the specifics of care provided on the ground and in the air should not change significantly, there are a number of considerations and limitations that the transport team must be aware of when moving the critically ill patient in a flight. What are the different environment on patient between on the land and on the air actually? As we are going higher, the pressure drops. It means that fewer available oxygen. As we are going higher, it gets drier. And as we are going higher, it gets colder. Then, what are the physiology changes on the patient's body? As we are going higher, barometric pressure and partial pressure of oxygen are decreasing. Whenever you reach 8,000 feet above the sea level, the partial pressure of oxygen decreased to 69 millimeter mercury. Hypoxemia happens when PaO2 less than 60 millimeter mercury or equal to oxygen saturation less than 90% based on oxyhemoglobin dissociation curve. Fortunately, today's aircraft are at cabin pressure equal to 5,000 to 8,000 feet. As for patients with pre-existing cardiac or pulmonary disease or anemia with lower partial pressure of oxygen, they cannot compensate. Their SaO2 may drop to 90%, where healthy person may compensate. So always prepare for oxygen in a certain medical condition even though they appear well oxygenated before flight. Based on discussed environment and physiology changes, there are some airway considerations. To maintain the airway patency, definitive airway by ET tube is the best airway adjunct options as it fully secures airway and the gold standard of airway management. You need to consider to release some its air on the cuff when the airplane ascending and reinflate on descending. The concept is just like whenever you are on an airplane. You open a bottled mineral water in the sky and it gets shrink as the airplane landed on the ground. With this phenomenon, the inflated air in the cuff may increase pressure on tracheal wall, result in necrosis. So it is suggested to inflate the cuff with sterile water. To clean the airway, you need to perform frequent, careful suction, and the use of humidified oxygen can avoid production of dry mucus. As for breathing considerations, yes, you need to determine the oxygen needed by the patient to maintain oxygen saturation more than 94% with flow and or with FiO2. But you have to be careful that oxygen saturation of 94% at the ground will later be oxygen saturation of 90% at cabin pressure altitude, where it is an ventilation emergency. This given formula will help you to measure FiO2 adjustment for altitude effects, as I will give the example on the next slide. The question is, if you give 30% FiO2 on the ground, how much FiO2 should you give on the air during the flight? Okay, since there is a different atmospheric pressure where it is 760 millimeter mercury on the ground and 565 millimeter mercury on the air. With this formula, you need to administer 40% FiO2 at 8,000 feet for your patient to deliver the same millimeter mercury of oxygen on the ground. The next question is, how many oxygen bottles do you need to bring? Only approved aviation oxygen bottles are allowed to be brought on flight. The one with the tank pressure of 2500 psi, 630 liters, and it lasts around 2 hours on 4 liters per minute. Important for you to calculate the total oxygen requirements for evacuation with the formula flow O2 times total time in minutes for both ground and flight time. If you take your patient fly with commercial or scheduled flight, have to be compliant with the medical guideline for airlines travel for passengers. These are lists of passengers unfit to fly. And special consideration for transporting those with specific problem. For acute respiratory distress syndrome, or ARDS, instituting the open lung strategy to open up the lung and keep it open, but by adjusting small tidal volume, less than 6 millimeter per kilogram to reduce shear forces, keeping peak inspiratory pressure or PIP below 30 to 35 centimeter H2O, and adjusting PEEP above inflection point to maintain. And for those asthma and COPD patients, listen carefully for expiratory wheezes. If expiratory wheezes ends before the start of the next inspiratory gas flow, dynamic hyperinflation should not occur. On the contrary, if inspiration with mechanical ventilation starts before full expiration, dynamic hyperinflation should occur. The air will be trapped in every cycle of breathing. As what happens in asthma, expiratory wheeze can be heard for 6 seconds, let's say. Expiratory time on mechanical ventilation should be more at least 6 seconds. For the for the cycle time, it means inspiration plus expiration should be at least 7 seconds. So the maximum ventilator should be 60 seconds divided by 7 seconds is at rate around 8.5 breaths per minute. To avoid lung hyperinflation, Institute a slow rate to allow adequate time for exhalation with adjusted inspirations expiration ratio and may require neuromuscular blockage. Also smaller tidal volume, 5 to 6 milliliter per kilogram. And this is the summary of suggestions for easier setup of transport ventilator setting. Last but not least, it is important to never turn ventilator alarms off. When it alarms, it means something wrong. Then you need to consult to consultant physicians in charge for any problem. Thank you very much. Hope you learned something from my sharing.